Hello, welcome everyone to the 36th lecture of Dr. Hyder Step 1. Can you guys hear my voice? Is my voice clear? Welcome. Good morning. Can you guys hear my voice? Okay, perfect. Okay. Uh, Hope everyone had a very good weekend. Um, this is a new week, and I'm pretty sure everyone is refreshed, rejuvenated from the weekend, and we are going to begin with our daily task. Before I do so, first and foremost, let me welcome the new students for our lectures. Our lecture is step-by-step read through first aid for USMLE Step 1, where what we do is we target 10 pages of first aid every day, more or less, and it's a 3 to 3.5 month to a maximum of a 4 month session where what we do is we read through the first aid text by text and we try to understand, we review and master the concept then and then during our lectures and associate high yield UWorld and emboss notes with our lecture. At the same time, we also give tasks, lesson schedules for the students in order to complete um, the preparation for the step one so that they can successfully enter their dedicated period after our 3 to 4 month session. So what we do is every day after giving our lecture, we ask our students to spend the rest of their day solving UWorld questions. And after that, what we do is every week we take assessment exams to make sure that the task which we completed during that week was successfully understood. So that's what we do. And these lectures that we conduct are conducted 5 days a week. That is from Monday to Friday, 9 a.m. Eastern timing to 1:30 p.m. more or less, 1:30 to maximum of 2, but we try to stick to 1:30 because we know that the students get pretty fatigued by the end of the lectures, so we try to keep it to a maximum of 4 hours, 4 to 4.5 hours, and we divide them into segments of revision and then preparing for the tasks, doing the tasks, then doing the questions, solving the UWorld notes, and then at last questions. So what we do is, first of all, for the first half an hour, we usually do a revision and review of our previous text. Then we read through first aid. That is our daily goal. And then after that, we solve the UWorld notes. And um, after that, what we do is finally we do 5 to 6 offline UWorld questions. So that's that. Um, Having said that, the students who would be joining from now on, the students who would be joining right now, um, we are going to start with our regular schedule. That is the schedule at which we started 3 months, almost a month ago. And the topics which were missed by the students will be covered again once we restart the lecture. So that's that. So let's say right now a new student would be studying renal. That's what we are studying right now, the renal system. After we are done with the renal system, we will keep on moving forward, finishing the organ system, and then we will move on to the basic sciences. After that, when we restart the lecture once again, we will start once again from CVS, endocrinology, gastroenterology, neurology, and we would be doing them. So if a new student joins, there is absolutely nothing to be worried about, thinking that the previous lectures will not be covered. The previous lectures actually will be covered, so there's absolutely nothing to be worried about. Okay. Having said that, do I have any questions regarding our lectures from the new students or any student for that matters? Do I have any questions? Okay, perfect. So hopefully no one has any question. If you guys have any questions, okay. Will nears will neuroscans be covered today? Neuroscans will be covered not today. Neuroscans will be covered most probably tomorrow. We apologize for that. It's because we are going to begin with renal physiology, which is quite a high yield topic. So hopefully from tomorrow we will cover neuroscans, but do not worry, we will not skip out on any scans. So hope that answers your questions. Does anyone have any other question? Okay, perfect. So if you guys have any questions, you guys can always send us an email and we will respond to your questions immediately. Having said that, we conducted a small neurology assessment exam on Saturday, and we have a discussion group on which we try to maintain on Facebook. And we would expect all our students to join the discussion group because we gave away the URL notes in the discussion group, and we also gave our assessment exams in the discussion group, and we also try to keep a note of all the questions the students have problems with when they solve the URL, and we would note a day to which during which what we will do is we will solve the questions that are there in the Facebook discussion group. So that's that. And what I wanted to know is how many of you guys have successfully taken the neurology assessment exam? Okay, that's very good. Who else? Okay, very good. Who else? Okay. So once you guys have finished the exam, please send us the okay. We will send you the answer sheet. Okay, very good, Dr. Hassam, Dr. Ahmed, Dr. Iman, Dr. Hassan. That is very good. So after you guys are done, so what we will do is we will send you the answer sheets by today. And all you have to do is just let us know how many questions you guys missed, and we will calculate the result score for you. Okay. And for everyone else who has not taken the exam, please take the exams as soon as you can, because that will allow you to understand whether you have successfully understood the neurology segment or not. Okay, so that's that. Having said that, how many of us have successfully completed doing UWorld questions? And how many questions did you guys do? 60, 50. Okay, that is very impressive. Okay, good. Okay, so that's that. Okay. Okay, perfect. Okay, so it's 9:20 as of right now, and what we would be doing is we would be starting with we would be starting with our revision and recapitulation from the previous topic. That's what we are going to do. So in the previous topic, what we did was we studied we studied the renal system, we studied the embryology, we studied the embryology and the anatomy portion of the renal system, and we're just going to do a short high yield step-by-step review of the system to see where we stand, and after that we will start with our regular daily lecture. Okay, so having said that, first of all, let's begin the revision. Is everyone ready? Okay. Okay, good. So my first question is, from which embryological layer, ectoderm, mesoderm, or endoderm, does the structures of the renal system arise from? Very simple, basic question. Very good. Mesoderm. Which part of the mesoderm? Intermediate mesoderm. Okay, very good. And okay, my next question is, pronephros will stay till week 4, right? How long does mesonephros stay? Mesonephros. First trimester. Okay, very good. How about metanephros? Metanephros. Nope. Okay, so metanephros. Very good. So the thing is, metanephros will first appear at the fifth week, and it will stay till it will continue through 32 to 36 weeks of gestations. And then after that, the metanephros usually gives rise to the metanephric blastema and the ureteric bud. What are the structures that are developed from the ureteric bud? What are the structures developed from the ureteric bud? Okay. If we have an intrauteral renal failure, what is the embryological pathology that could be associated with the with the baby after delivery? Potter syndrome. Okay. If a patient has horseshoe kidney, by which vessel can the ascent of the kidney be obstructed? That's very good. It's IMA. Okay. Next question. Okay. What's the name of the pathology where the ureteric bud bifurcates into two ureters before reaching the metanephric blastema? Duplex collecting system. Okay. What is the most common congenital or what is the most common bladder outlet obstruction, reason for bladder outlet obstruction in young male infants? Very good. Okay. Next question. Next question is okay. Our next question is, if a ureter, okay, can anyone tell me what's the relationship of the uterine artery and the common iliac artery to the ureters? Okay, so under the uterine artery and over the common iliac arteries. Okay, good. Next question. Next question is, can anyone tell me the components of the glomerular filtration barrier? Okay. Can anyone tell me what is the equation for renal clearance of a substance? What is the equation for renal clearance of a substance? Very good. It's a very easy basic question. It's basically UV by P. Now the question is, if you want to calculate the GFR of a person, which substance are you going to check? Which the clearance of which substance are you going to check? It's inulin. Okay. If you want to measure the renal plasma flow, which substance are you going to check? Okay. Good. Very good. And another one is okay. Another one is, can anyone tell me the equation for filtration fraction? The equation for filtration fraction? Okay, good. Okay, very good. And the next one is the last question is we studied a lot more about the filtration fractions. Then we talked a little bit more about the GFR and the renal plasma flows in the form of a table. And the last thing which I want to know is, can anyone tell me the equation for the fractional excretion of sodium? Fractional excretion of sodium. Okay, please refrain from looking at the book. Try to collect the information from your previous knowledge, and that will be better. Very good. The equation is sodium excreted divided by sodium filtered. Very good. Okay. Okay. That is absolutely amazing. Thank you so much for answering the questions correctly every time. Okay. I know you guys are refraining from looking at the book. Okay. So that's that. And we did a lot more last lecture. What we did was we discussed everything in a bit more details. For the new students who have joined the lectures, hopefully after the lectures, you guys will have an idea about how our lectures run. So that's that. And having said that, does anyone have any questions regarding the previous topic which we discussed? Okay, good. Okay, okay. So having said that, which one of these formulas do you advise to type in the exam sheet before the exam? We have a question from Dr. Hussam. Okay. The question is basically, okay. So my answer to this question is if you guys can go to the end of first aid, can you guys please go to the end of the first aid book and see that there is an equation page? Can you guys see the page and just write yes or no if you have not found it, or if you have not found the exam, the equations? All is there. Has everyone seen the equation portion of the first aid? Okay, good. Okay, okay. So this should be the third time or the fourth time that I'm advising you guys, but this is absolutely high yield. So what you guys have to do is when you sit for your actual USMLE Step 1 exam, your actual USMLE Step 1 exam, it's an 8 hour long exam. Okay, 8 hours long exam, and it's not a walk in the park. It's a very big uh, it's a very big exam, and the thing is basically the exam is a marathon, it's not a sprint. Okay, so what you have to do is, what we say is we have to pace ourselves. So by pacing, what we mean is you have to get into the flow of answering questions, and what you have to do is you are going to solve around 7 blocks of 40 questions. So that's 280 questions that you will be solving in one day. So what you have to do is you have to get into the pace of solving the questions in your actual exam. Okay. To answer Dr. Hossam's question, that is which equations are high yield, okay, from this lecture, my answer to that is the equation page in first aid has to be reviewed at more or less every 2 days or 3 days after you are done reading first aid, so that you can have a proper practice of writing these equations without looking at your book in a span of 5 to 6 minutes, all these equations. So what this would do is at the beginning of the actual exam, you will have a 15 minutes you will have a 15 minutes tutorial of how the exam simulator is going to run, and this is exactly the same simulator which they use in UWorld. So what you can do is you can skip out on watching the tutorial, and you can use that 15 minutes, that extra 15 minutes, to take your page, to take your rough page, or the page that they will be provided, or I mean the page that they will provide for you at the Prometric Center. You can use that page to write down the equations really fast. Okay. And what this will allow you to do is throughout the whole day that you take the exam, whenever you come across any questions, let's say from renal, from respiratory, or from cardiovascular system, it's if you come across a question where they require you to put in the numbers and do the calculations, okay, or biostats, what you can do is you can easily look at that rough page with the equation that you have written at the beginning of the exam, and then you can easily solve those questions, and those questions will be easy marks for you. The thing is, let's say that you do not do that. Let's say you do not write the equations in a different paper, and you start your exams without doing that. the next time when you come across a question which requires you to do the calculations, there's a big possibility that your mind will be so fatigued that you might forget the equations. Okay, so at the beginning of the exam, you should be you should, I know each and every one of you will be nervous, but you guys should still be refreshed enough to write these equations on a piece of paper, and then you guys can use that paper throughout the whole day to associate the calculated portions of the exam to it. Is that clear to everyone? Has everyone understood what I just said? This is an exam tactic. Has everyone understood what I said? Okay. So in order for you guys to have the practice of writing these questions down, of writing these equations down on a piece of paper, you guys have to practice this almost every other day to make sure that you guys don't miss out on any equations. Okay, am I clear? Do we have any other question from any students before we begin? It's 9:30 as of right now, and we would like to begin with our daily task. If you do not have any questions, please write no so that I understand that you guys are devoid of all questions. Okay, Dr. Naud is kind enough to share the page number with us all. Page number for the equation is page 707. Okay. Okay. Another one is we have shared the subscription for Dr. Najib for this week. We selected 5 students at random. And the thing is, our lecture, that is Dr. Hydri Step 1, will provide subscription for Dr. Najib and will provide subscription for physio. And the thing is, we would be starting physio very soon when our lectures need the help of picture mnemonics. Okay, when we need the help of picture mnemonics, that is during microbiology, biochemistry, then we would be starting physio. But we have already started giving out subscriptions of Dr. Najib. And to the students who received the subscriptions, have you guys started using Dr. Najib as of yet? Who are the students who received the subscriptions for Dr. Najib, which were selected by our team randomly? Okay, so what you guys need to do is we selected 5 students. So you guys have an email amongst yourselves to realize who is using which day. I mean, who needs which day in order to use the subscription. Okay, so not everyone can use in a single day because the subscription will allow only one participant to enter, right? So just it will be better if you guys can talk amongst yourself and fix a day for everyone, so that only one individual can log in and download the download the lectures. Okay, so that's that. Okay, and if anyone else has any other questions, now's the best time to ask. If not, it's 9:35 and we will begin with our daily task. To the new students who has joined our lecture, do you guys have any questions? Okay, no questions. Then let's begin with our daily task. Okay, so what we are going to do is we are going to start with the nephron transport physiology. Is everyone ready? Yes or no? Can I get some answers? Okay, perfect. Okay, let's begin. What we are going to do is we are going to share our screen, and then then we are going to begin. Okay. Okay. So can everyone see our screen over here? Can everyone see our screen properly? Can everyone see our screen? Yes or no? Okay, perfect. Okay, let's begin. So what we are going to do is we are going to try and understand, and the what we're going to do is we're going to try and understand the nephron transport physiology, and we will start this from today's lecture. This is a very high yield topic for your basic understanding, because what will happen is, although you might not expect a lot of questions from over here regarding the text, but the understanding of these physiologies is extremely important to answer the physiology sections of the text, I mean of the URL. And if you can master this, then this will also allow you to understand the pathologies behind the renal system. So that's what it is. So right before we do that, what we are going to do is we're going to take a short page and then we're going to begin. Okay. So first and foremost, the nephron transport physiology, meaning that how is a substance transported from the from the duct, right? From the duct into the cell and then into the blood. So basically the mechanism of reabsorption, and also we're also going to discuss the mechanism of tubular reabsorption and tubular secretion, and that's that. So before we do that, okay, what we're going to do is we're going to start with the proximal collecting tube. We're going to start with the proximal convoluted tubule, PCT. What we're going to start is PCT. PCT is the first important segment of the nephron system. So that's what we're going to do. Okay. Okay. So first and foremost, what we're going to do is this is your PCT cell. Okay. This is your PCT cell. This is basically the lumen, which contains mainly the filtrated portion of the blood, that is the urine, and this is the blood. Okay. And we already know that the lumen contains the filtered portions from the glomerulus. Okay, so right now what we're going to do is we're going to tell you exactly what's going on over here. How is a substance reabsorbed? Okay, from this segment over here into the blood, and there are several different mechanisms which are high yield, which we're going to discuss right now. My first question to you guys before I begin is, which substance is the most important to be reabsorbed via tubular reabsorption from the proximal convoluted tubule? Okay, that is the first question. And the answer is absolutely correct. The answer is sodium. Okay, so the answer is sodium because the sodium has to be reabsorbed. Can anyone tell me very quick how much of the sodium do we expect to get reabsorbed from the proximal collected tubule, from the proximal convoluted tubule? 60%. That is very good. So 60% of the sodium has to be absorbed from over here. Okay. So basically what's going on is the first thing that happens is, let's say that the sodium over here is already in the lumen. Okay. So sodium will get reabsorbed via various mechanisms. Okay. So the first thing is over here, what we have is a co-transporter. Okay. The first mechanism is that the sodium over here in the lumen will get absorbed via a co-transporter, and this co-transporter will not only absorb sodium, it will also absorb glucose with it. So sodium glucose co-transporter. Okay, so can anyone tell me what type of a mechanism this is? Simple diffusion, facilitated diffusion, active transport. What mechanism is this co-transport? Okay, very good. So this first mechanism, okay, this first mechanism over here with sodium and glucose, this mechanism is via facilitated diffusion. Facilitated diffusion. So with facilitated diffusion, that is with the help of a co-transport, the sodium enters. After the sodium enters, this sodium, what this will do is this will come over here. And from over here, it will enter into the blood very easily via another transport mechanism. They will enter into the blood by another transport mechanism. And this mechanism by which the sodium will enter into the blood, that is the sodium will go this way, and the potassium from the blood will enter this way. Okay, so potassium will enter and the sodium will exit. Okay, and this is occurring via a sodium potassium ATPase channel. Can anyone tell me what type of a mechanism this sodium potassium ATPase channel is? Active transport, primary or secondary? Good. So this is basically an active transport. So that's basically what's happening over here. Okay. After that, what will happen is that the next step, okay, so sodium is being absorbed like this while with glucose. There's another way by which sodium can get reabsorbed. Okay, there's another way, that is sodium has another channel over here. Okay, so what sodium will do is sodium will enter from the lumen into the cell, and at the same time hydrogen over here from the lumen, from the cell will enter into the lumen. Okay, this is called a sodium hydrogen antiporter. Sodium hydrogen antiporter. And after the sodium enters, the sodium will exit the cell via the sodium potassium ATPase. Okay, so this is how basically sodium will enter into the proximal convoluted tubular cell from the lumen, and then from there it will go inside the blood. Now if I were to tell you that let's say this lumen is not working, this I mean this channel is not working, this channel is not working, what would happen? What would happen basically is that the patient in whom these channels are not working, these patients will have a high amount of sodium natriuresis. Okay, so there will be a high amount of natriuresis, and the patient will lose out on a lot of sodium and then be hyponatremic very quickly. Okay, so that is exactly what's going on over here. Okay, next one. There's another thing that is high yield that is going on in proximal convoluted tubule. So we have just discussed the mechanism of sodium reabsorption. Okay, there's another high yield mechanism that's been going on over here. Okay, and that is for the hydrogen and bicarbonate. Okay, so that is for the hydrogen and bicarbonate. Okay, so what's going on is over here, what we have is we have carbon dioxide. Okay, and we have the water. We have water and carbon dioxide. Where is this carbon dioxide coming from? This carbon dioxide is produced in the cell as a result of the cellular metabolism, right? And the water that is coming over here is the water that is reabsorbed from over here, either with sodium, or water is reabsorbed via passive, uh, just by itself, right, via diffusion. So what happens is the carbon dioxide and the water, they combine together to form, okay, they combine together to form carbonic acid, which is an extremely volatile acid. Okay, so and this occurs in the presence of carbonic anhydrase. This carbonic acid breaks down into two substances, that is that is hydrogen and bicarbonate. Okay, so why is this important? This is important because the hydrogen that is formed over here will be released into the cell, I mean into the lumen from the cell, and this will allow the sodium to get reabsorbed. The one which we just talked about a bit before is that the hydrogen that will be released into the lumen will allow the sodium to get reabsorbed from the lumen into the cell. This is known as the sodium hydrogen antiporter. Okay, sodium hydrogen antiporter, which we just talked about. There's a very high yield hormone which helps activate this antiporter. Okay, the high yield hormone that helps activate this antiporter is angiotensin 2. Okay, angiotensin 2, what this does is this activates the sodium hydrogen antiporter, which allows more sodium to be reabsorbed and more hydrogen to be released. Okay, and that's that. Okay, so please make sure that you remember this. I'm pretty sure that we already talked about this when we discussed the angiotensin in the mechanism of cardiovascular system and the mechanism of the endocrinology. If we have not, I mean, if you guys do not remember the mechanism, do not worry, because we will get into the details of this in the future. Okay, so that's exactly what's going on over here. Now, what happens after the hydrogen is released? Okay, now what happens after the hydrogen comes in the lumen? After the hydrogen comes in the lumen, after the hydrogen, it comes into the lumen, the hydrogen will bind again. Okay, the hydrogen will again bind with the bicarbonates that is over here in the lumen. Okay, will form carbonic acid, will form carbonic acid. This carbonic acid once again will form water and carbon dioxide. Okay, and this water that is produced, this water will get reabsorbed over here and help in this cycle. So this is known as the carbonic acid cycle that keeps on happening in the proximal convoluted tubular cell and the lumen. So this is important to maintain the acid-base balance, and that's that. Okay, there's another high yield ion that is being reabsorbed over here. Okay, another high yield ion. So these are all the things that is happening in the proximal convoluted tubule. Okay, so that's that. Another high yield ion that is being reabsorbed over here. Okay, 1 second. Another high yield ion that is being reabsorbed in the proximal convoluted tubule is Okay. Another high yield ion that is being reabsorbed in the proximal convoluted tubule is chloride ion. Okay. Chloride is being reabsorbed, and at the same time, this is also an N-type order in which a base is being released. A base. Okay. So can anyone tell me the most common basic substance? Base. Can anyone tell me the most common basic substance that could be released from the proximal convoluted tubule? Bicarbonate. That's what it is. So bicarbonate. So bicarbonate chloride, chloride bicarbonate, N-type order. That's exactly what's happening over here. So this is basically the mechanism of the proximal convoluted tubule. Okay, the proximal convoluted tubule. Now the thing is, the mechanism. What I want you guys to understand is the mechanism by which sodium has reabsorbed glucose. That is the sodium glucose and sodium glucose co-transporter. The mechanism by which sodium has done this. Okay, sodium. What sodium does is sodium also does the same thing for amino acids. Okay, for let's say if anyone has small amount of amino acids that's coming down in the lumen, sodium will also have a sodium amino acid co-transporter. So that's how amino acids are reabsorbed from the lumen. So that's what I want you guys to understand. Okay, so that's that. Okay, another thing is there is also another co-transporter. Okay, there is also another co-transporter. The co-transporter. So we have sodium glucose co-transporter. We have a sodium amino acid co-transporter. Okay. We also have a sodium. We also have a sodium phosphate co-transporter. Okay. Sodium phosphate co-transporter. And after the sodium gets reabsorbed into the proximal convoluted tubule, it will enter the blood via sodium potassium ATPase. So that's exactly what's going on over here. Okay, so every time a sodium uses a co-transporter to enter the cell, it leaves the cell and enters the blood via a sodium potassium antiporter. I mean a sodium potassium ATPase channel. Okay, so that's exactly what happens over here. And once again, what is the amount of sodium that is reabsorbed in the proximal convoluted tubule? The amount of sodium that is reabsorbed in the proximal convoluted tubule is 65 to 80%. 80% is reabsorbed in the proximal convoluted tubule. Okay, so this is absolutely very high yield for your USMLE step 1, because you will be tested on this in your exam when they will ask you how much, which portion is involved in the absorption of 65 to 80% of the sodium. The answer is proximal convoluted tubule. Okay, that's that. Okay, so having said that, we're done with the discussion of proximal convoluted tubule. Okay, now what we're going to do is we're going to move down. After proximal convoluted tubule, what we're going to do is we're going to move down into the thick and thin limb of the loop of Henle. Okay, the thick and thin limb of the loop of Henle, and see what's going on over there. Okay, so that's what we will do. Okay, so has everyone understood the proximal convoluted tubule, what's going on over here? Has everyone understood what's going on over here? Okay, extremely easy to understand, am I correct? Just a very basic concept. Okay, good. Please let me know if you guys have any questions. That's that. Okay, good. Next one. Next one is, okay, next one. Next one is what we're going to discuss is the thick and thin limb of the ascending limb of the thin descending limb of the loop of Henle, and the thick ascending limb of the loop of Henle. In the thin descending limb of the loop of Henle, there's not really much going on over here, except the fact that water is being passively reabsorbed. So if we have water over here, water will get, let's say that this is the thin descending limb of loop of Henle. Okay, so what's happening in the thin descending limb of the loop of Henle is that the water will get passively reabsorbed. Okay, and this reabsorption of water, this passive reabsorption of water, will make the urine hypertonic or hypotonic. Fast questions, and I expect fast answers. Hypertonic or hypotonic? If water gets passively reabsorbed, hypertonic. Very good. Hypertonic, meaning that the serum osmolarity, I mean that the urine osmolarity will obviously increase if the water is reabsorbed. So that's that. So that's basically the main function of the thin descending limb of the loop of Henle, is concentrating the urine over here by passively reabsorbing the water. Okay. Next one. Next one.
Doctor, you have muted yourself.
Okay. My bad. I apologize. Okay. Okay, I apologize. My bad. I'm sorry. Okay. So what I was saying was said that, look, right now what we're going to discuss is we're going to discuss the thick ascending limb of the loop of Henle. Over here, what we have is we have a very high yield channel, which is responsible for reabsorbing the sodium, potassium, and chloride over here from the lumen into the blood. And how does that happen? That happens by the help of a very important channel known as the sodium potassium 2 chloride channel. Sodium potassium 2 chloride channel. And what is this channel doing? What this channel basically is doing is this channel is reabsorbing the sodium, potassium, and 2 chloride from the lumen into the cell. And once it enters the cell, if I have to ask you this sodium, how will it reach the blood? What will be your answer, please? If the sodium has to reach the blood from the cell, how will it reach the blood? Via which mechanism? Can I get some fast answers? Very good. Okay, very good. Once the sodium enters via this channel, first of all, the sodium potassium 2 chloride channel, what mechanism are they using in regards to reabsorption of the sodium? Active transport, facilitated diffusion, passive diffusion, which one? Which one? Does anyone have any idea? Which mechanism is sodium potassium 2 chloride channel using? Okay, very good. Okay, so basically sodium potassium 2 chloride channel. Sodium potassium 2 chloride channel, it's mainly a channel that uses facilitated diffusion. Facilitated sodium potassium 2 chloride channel is mainly a channel that uses basically facilitated diffusion and also a little bit of active transport. Also a little bit of active transport. So the movement of sodium and potassium, movement of the sodium and potassium will facilitate the movement of sodium and potassium will facilitate the movement of the chloride over here from the lumen inside the cell. And that's that. And also the sodium and potassium that enters, if it uses some form of energy to enter the cell together, okay, then they are using one mechanism of active transport. Okay, so after the sodium enters the cell, from the cell, the sodium enters the blood via sodium potassium ATPase, and the potassium which enters the cell, the potassium leaves the cell, so the sodium is leaving by sodium potassium ATPase. Okay, the potassium is entering, sodium is leaving, and our goal is done for the sodium. So sodium has entered. Potassium, what this will do is that the potassium which comes from over here, it exits the cell via simple diffusion, and so does the chloride. So does the chloride. Even the chloride exits the cell via simple diffusion. Okay, so that's that. Okay, So this diffusion channel that is being, this diffusion, what this does is, this diffusion also causes, not a lot of people actually talk about this, but this diffusion gradient that's been created over here, that is the diffusion along the electrochemical gradient. This diffusion also allows the reabsorption of magnesium and calcium. So calcium and magnesium also enters the blood via the route that is known as paracellular route. Paracellular route. Paracellular route. Apologies for my handwriting for over here. This is paracellular route. Okay, so that's exactly what's going on in the thick ascending loop of Henle. That's all we need to know. Okay, are we clear about this? Are we clear about this? Yes or no? What's happening in the thick ascending loop of Henle? Once again, what's happening in the thick ascending limb of loop of Henle is, in the thick ascending limb of loop of Henle, you have the sodium potassium 2 chloride, which is being reabsorbed by the sodium potassium 2 chloride channel. Sodium enters the blood via sodium potassium ATPase. Potassium enters the blood via passive diffusion. Chloride enters via passive diffusion. And this diffusion gradient creates an electrochemical gradient by which magnesium and calcium can also get reabsorbed passively via paracellular route. That's it. That's all we need to know. Are we clear now? Are we clear now? Okay. Is everyone clear before I move on to the next segment of the nephron? Okay, good. Looks like everyone's clear. So let's move on. Then the next segment that I want to talk about, the next segment that I want to talk about is the distal convoluted tubule. Okay, the next segment that I want to talk about is the distal convoluted tubule. So what's going on over here? Okay, so what's going on over here is, once again, over here, if I have to ask you, once again, if I have to ask you over here in the thick ascending limb of loop of Henle, what is the percentage of sodium that is being reabsorbed? What will be your answer? What will be your answer? Good, very good. The percentage of sodium that is being reabsorbed in thick ascending limb of loop of Henle is 10 to 20%. Okay, 10 to 20%. Make sure you remember the percentages of the sodium because a lot of questions will come from this and you will. Okay, next one. Next one is distal convoluted tubule. Even in distal convoluted tubule, you have sodium reabsorption that's occurring. So what happens over here is, we have a channel over here. This channel is known as, okay, this channel is known as sodium and chloride, sodium chloride co-transporter. The sodium and chloride is being co-transported by this co-transporting channel. So what happens is, what happens is, when this sodium enters, okay, so when this sodium enters, the sodium once again leaves the cell. Whenever sodium enters the cell of the nephron, the sodium will always leave the cell via sodium potassium ATPase, like we just mentioned before, okay? Sodium potassium will always leave the cell via sodium potassium ATPase, okay? Another thing that's happening over here is that there's another channel over here, which is known as sodium calcium exchanger. This is known as a sodium calcium exchanger channel. And so this sodium calcium exchanger channel, so the thing is, the calcium will leave the cell and the sodium will enter the cell. Okay, the sodium will enter the cell. And the thing is, the calcium will leave the cell to make sure that enough sodium enters. Okay, right now, the thing is, if I have to block this channel, let's say that I block this channel via thiazide diuretic, because of the thiazide diuretic that we use, for example, hydrochlorothiazide, right? Those diuretics, they block the sodium chloride co-transporter over here. If we block this channel, do we need more sodium to enter the cell or less sodium to enter the cell? If we block the channel, will more sodium enter or less sodium enter the cell? Do we need more sodium to enter? More sodium to enter. If we need more sodium to enter the cell, will calcium be more, what will that do to the calcium ion? What will that do to the calcium ion? Calcium. So my first question is hydrochlorothiazide. Does thiazide cause hypercalcemia? Yes or no? Does thiazide cause hypercalcemia? Okay, good. Now the question is, how does thiazide cause hypercalcemia? That is my question. And the explanation is, if thiazide blocks the sodium chloride channel over here, so not enough sodium is entering from the lumen. So sodium has to enter from the blood into the lumen. In order for sodium to enter from the blood into the lumen, the calcium has to enter the blood. Okay, the calcium enters the blood because the calcium also enters the cell from the lumen. The calcium also enters the cell from the lumen by simple diffusion. And this calcium, if this is blocked, will get reabsorbed way faster because the sodium has to enter the cell, right? So this is the mechanism by which thiazide causes hypercalcemia. Okay, this is the mechanism by which thiazide causes hypercalcemia. Are we clear on this? Are we clear on how thiazide causes hypercalcemia? Okay, good. Very good. Okay. We have another thing that is happening over here. We have a very high yield hormone, which works in the distal convoluted tubule. Okay, we have a very high yield hormone, which works in the distal convoluted tubule. This hormone is known as parathyroid hormone. Do you guys remember that we talked about the parathyroid hormone before when we discussed the parathyroid hormone that it works in the DCT? Yes, so that hormone over here is working in the DCT. Okay, once again, how does hydrochlorothiazide causes hypercalcemia? First of all, let's say that if I tell you that a certain amount of sodium is always needed in the cell. Okay, a certain amount of sodium is always needed into the cell to maintain the cellular homeostasis. Okay, so in order to maintain that level inside the cell, let's say if we block this channel via thiazide diuretic, they block the sodium chloride exchanger. I mean the sodium chloride co-transporter over here. If we block this channel, will there be enough sodium inside the cell to maintain the cellular homeostasis? Yes or no? Yes or no? To the students who have confusion with this? No. So do we not need enough sodium inside the cell to maintain the cellular homeostasis? Yes. Yes or no? Yes, we do. We need enough sodium in the cell to maintain the cellular homeostasis. So if this channel is not working, then this channel obviously has to overwork, right? Because this channel right now has to maintain the sodium level inside the cell to maintain the cellular homeostasis. In order for this channel to maintain the cellular homeostasis, will this channel have to work more or work less? Will this channel work more or work less? Work more. If this channel works more, then will there be more calcium in the blood or less calcium in the blood? More calcium in the blood, right? That is great. So that's exactly what's happening. That's how thiazide causes hypercalcemia. Okay, are we clear? Are we clear? Okay, perfect. Okay, so having said that, let's move on to the next segment of the nephron. Having said that, let's move on to the next segment of the nephron. Okay, before we move on to the next segment, we were talking about the parathyroid hormone. Parathyroid hormone, does it cause hypercalcemia or hypocalcemia? Fast answers, please. Hypercalcemia or hypocalcemia? Parathyroid hormone. Hypercalcemia. Very good. If the parathyroid hormone has to cause hypercalcemia, will it cause more Will it increase the work of the sodium calcium exchanger or decrease the work of sodium calcium exchanger? Increase the sodium calcium exchanger. Very good. If the sodium calcium exchanger work increases, will there be more calcium reabsorption or less calcium reabsorption? More calcium reabsorption. So that's exactly how parathyroid hormone increases the serum calcium level. Okay, so that's exactly how the parathyroid hormone increases the serum calcium level. Okay, good. Next one. Next one is how much of sodium is being reabsorbed in the distal collecting tubule? What is the percentage of sodium reabsorption from the distal convoluted tubule? The percentage of sodium that is reabsorbed is 5 to 10%. 5 to 10%. So first of all, 65 to 80, 10 to 20, now 5 to 10%. Okay. Having said that, we are very close towards the end of the having said that, we are very close towards the end of the lecture today. Okay, so we will be ending the lecture after we study the collecting tubule. How happy are you guys? Do I have any students who are happy that the lecture will end? Okay, I was just joking. Okay, it was just a joke. The lecture will not end. The lecture will not end after this. Okay, just wanted to see if you guys were eager to end the lecture or not. Okay, so okay, very very bad joke. Should not have done that. My apologies. Okay, my apologies for getting your hopes up high. Okay, we're still going to stick to the whole thing. Okay, could you repeat parathyroid hormone again? Of course I will. So parathyroid hormone, what's happening over here is the parathyroid hormone, first of all, it works in the distal convoluted tubule. Once the parathyroid hormone comes, the parathyroid hormone binds to the tubule, and then it causes increased work of the sodium calcium exchanger. The sodium enters, the calcium exits, and in order for this, more calcium has to be reabsorbed from over here. Okay, are we clear? That's how the parathyroid hormone will be working. Okay, good. Next one. Next one is the next portion that we are going to discuss is the collecting tubule. Okay, so the next portion that we're going to discuss is the collecting tubule. And a lot of mechanisms are taking place in the collecting tubules, and a lot of high yield hormones are working over here. Okay, so we're going to take a little bit of time before we discuss the whole thing. First of all, let's identify the three types of cells over here. First of all, this cell over here is at the top. Okay, so we know that cells that the cell over here that is at the top, this cell is known as the principal cell. Okay, this cell is known as the principal cell. Okay, and then we have another cell over here. Okay, this cell is known as alpha intercalated cell, and then we have another cell over here. This cell is known as the beta intercalated cell. Okay, so what's happening in the principal cell? Okay, so first of all, the first thing that I want to talk about is once again I want to begin with the sodium. Okay, so sodium over here is being absorbed via a channel. Okay, so sodium is being absorbed by a channel. This channel allows free passage of sodium from the lumen inside the cell, and this sodium, once it enters, the sodium will exit the cell via a sodium potassium ATPase. Okay, so that's what's happening with sodium potassium ATPase. Okay, another thing is in the principal cell allows the release of potassium from this cell into the lumen. Okay, the principal cell allows the release of potassium into the lumen. So if potassium have had to leave the blood and enter the lumen, then they would always use the principal cell to exit the lumen. Okay, so that's that. So these are the two things that I talked about. First of all, via the sodium potassium ATPase, the sodium that enters is reabsorbed. The potassium that enters the cell is released into the lumen. Okay, next one. The next thing that I want to talk about is this receptor over here. Okay, there's another receptor. This receptor is a very high yield receptor for the principal cell. This receptor is known as aquaporin. This receptor is known as, I'm sorry, this receptor is known as a V2 receptor. My apologies. This receptor is known as a V2 receptor. The aquaporins are the ones that is formed after ADH binds to the receptor. So ADH, what ADH does is ADH comes and binds to the V2 receptor. After the ADH comes to V2 receptor, they form these small protein channels known as aquaporins. And these aquaporin channels, they form a channel over here for reabsorption of water. So that's that. Now, if the serum osmolarity of the body is increased, will we need more ADH or less ADH? If serum osmolarity is increased, will we need more ADH or less ADH? More ADH. If more ADH is working, then more ADH over here will allow the reabsorption of more water from the lumen, okay, by forming more aquaporin channels. So that's exactly what will happen over here. Okay. Another high yield hormone that is working over here, another high yield hormone that is working over here, this hormone is known as, okay, this hormone over here, this hormone is known as aldosterone. Okay, I'm pretty sure we all know how this hormone works, right? This hormone aldosterone, okay, aldosterone, will it cause more reabsorption of water or less reabsorption of water? Aldosterone, sodium, renin, angiotensin, aldosterone system. Will this cause more or less reabsorption of water? How about potassium? How about potassium? Will it cause more secretion of potassium or less secretion of aldosterone? Will it cause more secretion or less secretion of potassium? Okay. If we have a patient with hyperaldosteronism, will there be hypokalemia or hyperkalemia? Hypokalemia. Why is there hypokalemia? Because of more secretion of potassium or less secretion of potassium? Secretion, not reabsorption. Secretion. More secretion of potassium. Very good. So the aldosterone that is over here. So first of all, in renin-angiotensin aldosterone system, if it's activated, then more aldosterone will be released. Aldosterone is responsible for more reabsorption of water and more secretion of potassium. So potassium secretion will increase and water reabsorption will increase. Okay, so that's that. Okay, aldosterone over here, aldosterone. So aldosterone works in two cells. First of all, aldosterone works in the principal cell for water reabsorption and secretion of the potassium ion. Aldosterone also works in the alpha intercalated cells. Aldosterone also works in the alpha intercalated cells. And aldosterone, what it does is in the alpha intercalated cells, these aldosterones, they are responsible for this channel that is known as the hydrogen ATPase channel, which releases the hydrogen from the cell into the lumen. Okay. And they are also responsible for this another channel over here. This channel is known as chloride bicarbonate antiporter. Bicarbonate and chloride antiporter. So chloride enters and bicarbonate exits the cell and enters the blood. Right now, if aldosterone comes and works, if there's excess working of the aldosterone, for example, there's a high activation of the renin-angiotensin aldosterone system, my question to you is, will there be more secretion of, will there be more release of the hydrogen into the lumen or less release of hydrogen into the lumen? You mean excretion. Okay, what I mean is that the aldosterone, first of all, let's talk about the aldosterone in the principal cell. If the aldosterone works in the principal cell, will this allow the kidney to release more potassium or less potassium? And the answer is more potassium. And the next one is, if aldosterone works in the alpha intercalated cell, if the aldosterone works, will this allow for more hydrogen to be released or less hydrogen to be released? And the answer is more hydrogen to be released. And the thing is, if the aldosterone comes and works in the alpha intercalated cell, and overworks the bicarbonate chloride channel that we have over here, will there be more reabsorption of bicarbonate or less reabsorption of bicarbonate? Bicarbonate chloride channel. Will there be more reabsorption of bicarbonate or less reabsorption? More bicarbonate. Very good. More bicarbonate. Okay. So as a result, what would happen to the acid-base balance? Will there be acidosis or alkalosis? Metabolic alkalosis, because hydrogen is being released and bicarbonate is being reabsorbed. That's that. Okay. Then we have another channel over here. This cell is known as the beta intercalated cell. This beta intercalated cell over here, this beta intercalated cell, this cell is responsible for another type of mechanism, but this is a lesser yield mechanism. This is not very heavily tested. And the easiest way to understand this, okay, the easiest way to understand this is that this channel is the exact same as this channel over here. So what's happening in the beta intercalated cell is the almost exact opposite of what's happening in alpha intercalated cell. So over here, bicarbonate was being reabsorbed, chloride was being secreted, and the exact opposite what happens over here, that is, chloride is reabsorbed and bicarbonate is being secreted. And this channel over here comes into this channel, meaning that that the hydrogen which was being released that is now being reabsorbed. So the exact opposite. The hydrogen is being reabsorbed via hydrogen potassium ATPase. Hydrogen potassium ATPase. If this channels overwork, will the patient have metabolic acidosis or metabolic alkalosis? Metabolic acidosis. Okay. So alpha intercalated cell, metabolic alkalosis. Excess working can cause metabolic alkalosis. Beta intercalated cell, excess working can cause metabolic acidosis. Okay. Now, what is the percentage of sodium that is being reabsorbed from this collecting tubule and the cells? The percentage of sodium that is reabsorbed from all this portion is 3 to 5%. 3 to 5%. Okay, 3 to 5%. Okay. So what I'm going to do is proximal convoluted tubule, 65 to 80%. Okay. Loop of Henle, 10 to 20%. DCT, 5 to 10%. Collecting tubule, 3 to 5%. Okay, these are the percentages of sodium that is being reabsorbed from each and every segment of the nephron. Okay. Are we clear on how the different portions of the kidney is working? Okay, should be very, very easy to understand. Right now, has this, okay, so my question is, has this description of the different cells of the nephron helped you guys out understanding the different segments of how the nephrons are working? Because the thing is, the text in first aid, if you guys understand this lecture over here right now, if you read the text in first aid right now, you will realize that we have discussed each and every text, each and every portion of the first aid in this lecture. And if you read it once again, you guys can see that it will be extremely easy for you to understand. Okay, having said that, I will repeat once again about the alpha and beta and the intercalated cell for Dr. Hussain. So what happens is in alpha intercalated and beta intercalated cells, you have a hydrogen ATPase that is actively releasing hydrogen into the lumen, and bicarbonate chloride antiporter that is actively reabsorbing bicarbonate. As a result, if this channel overworks, the patients can have metabolic alkalosis. In beta intercalated cell, the exact opposite happens. That is, the bicarbonate is being released and hydrogen is being actively reabsorbed. Okay, so this is known as, these are the things that is happening in beta intercalated cell. If there's overwork, then these patients can have metabolic acidosis. That's all I mean. That's all I wanted you to understand. Okay, so having said that, have you guys understood this topic so that we can move on? Yes or no? Have you guys understood this topic so that we can move on? Okay. Okay, so please do not hesitate to ask any questions if you guys have any questions. Okay, right now. So what I want to discuss is the next thing over here. The next thing that we will discuss today, after discussing that, is we will discuss about RTDs. RTDs are renal tubular defects. Okay, these are known as renal tubular defects. Okay, so what is a renal tubular defect? So basically, renal tubular defect is the defect of these channels that we have just discussed. So let's say if a certain channel is not working, let's say if a certain channel is not working, will there be more reabsorption of a certain substance or less reabsorption of a certain substance? Let's say that the sodium channel is not working over here. So will there be more or less? Exactly. So there will be less reabsorption of sodium. As a result, will the patients have hyponatremia or hypernatremia? Very easy to understand. If there's less activation or less working of the sodium channel, will there be hypo or hypo? Okay, there will be hyponatremia. So this is also known as this renal tubular defects, according to MBOS, some other question banks, even in your actual USMLE step exam. This pathology is also known as salt-losing nephropathy. Okay, so please write this down. This is also known as salt-losing nephropathy. Okay, so renal tubular defect. So renal tubular defects. So the thing is, let me draw let me draw a portion of the nephron over here. Okay, so this is the segment of the nephron. So I just want to tell you the different names of, okay, just want to tell you the different names of different types of pathologies for the different segments of the nephron, which are responsible for the defect of the channels. If there is a defect of the channel in the proximal convoluted tubules, okay, if there is a defect in the channels of the proximal convoluted tubule, okay, this defect is known as Fanconi syndrome. Okay, this is known as the Fanconi syndrome. Okay. If there is a defect of this channel from this portion that is in the thick ascending limb of the loop of Henle, this defect is known as Bartter syndrome. Bartter. Okay, Bartter syndrome. Okay, next one. Next one is if there's a defect in this segment that is in the distal convoluted tubule, this segment is known as, this defect is known as Gittleman syndrome. Gittleman syndrome. And the last one, the last but not the least, we have another syndrome that is over here. If there is a syndrome in this segment that is in the collecting duct, this segment is known as Liddle. Not little, it's Liddle, 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 Little syndrome. So that's that. Having said that, I just wanted to make you guys well acquainted with the names over here, because we're going to jump into the lecture where we're going to discuss exactly what happens, in each of these diseases. Okay. So the first defect that I want to talk about is Fanconi syndrome. Fanconi syndrome is the syndrome that is happening over here. Okay. So the defects is basically that this is a reabsorption defect in the proximal convoluted tubule. Okay, there will be, okay, so my first question is, do you guys remember that we talked about the fact how sodium in proximal convoluted tubule, sodium does not get reabsorbed by itself. Sodium gets reabsorbed with amino acid, glucose, and phosphate, and bicarbonate, yes or no? Yes. So if there is defect of those channels where sodium is not being reabsorbed, will there be more reabsorption of glucose, amino acid, bicarbonate, and phosphate, or less? Less. Exactly. So that's exactly what's happening over here. That's exactly what's happening over here. You have increased excretion of amino acids, glucose, bicarbonate, and phosphate, and all other substances that are being reabsorbed by the proximal convoluted tubule. And as a result, what would happen is this may also lead to metabolic acidosis. Okay, this may also lead to metabolic acidosis. Okay, how will there be metabolic acidosis? There will be metabolic acidosis because there will be increased excretion of bicarbonate ion. If bicarbonate ion is being excreted, that is, the bicarbonate cannot be reabsorbed. Okay, there will be more metabolic acidosis. Along with this, the patients can also get hypophosphatemia. How? Because the phosphate over here was being reabsorbed by the sodium phosphate cotransporter. And if there's decreased phosphate, phosphate is an important component of forming for osteogenesis. So the patients can also have osteopenia. Osteopenia. Okay. What are the causes of Fanconi syndrome? Okay, the causes of Fanconi syndrome is, first of all, there is a hereditary defect, that is Wilson's disease. Okay, then tyrosinemia, glycogen storage disorder, So out of the hereditary defects, we have Wilson disease, then we have tyrosinemia, okay, and then we have glycogen storage disease. We also have ischemia, multiple myeloma, nephrotoxins, and drugs such as ifosfamide and cisplatin, and lead poisoning. Out of all of this, the high yield ones are Wilson disease. That is exactly what you have to remember, that Wilson's disease can cause hereditary defect of the Fanconi syndrome. Hereditary defect which can cause Fanconi syndrome. Okay, and drugs such as ifosfamide and cisplatin can cause the Fanconi syndrome. So what we will do is we would see if we can come up with a small mnemonic that can help us remember the causes of Fanconi syndrome. Okay, so so what we have over here is this young boy. Okay, so what we have over here is this young boy. This young boy's, okay, his name is Wilson. Okay, young boy whose name is Wilson. Okay, Wilson always tries. Wilson tries to hide. Wilson tries to hide candies. Okay, since he's a young boy, he doesn't want to share his candies with anyone else, so he always tries to hide them. Okay, so Wilson always tries to hide his candies. And how many candies did he have? How many candies did Wilson have? Wilson had multiple candies, not one type of candy. He had multiple types of candies. Okay, and what happened is over time, okay, over time, these candies, what they did was they damaged Wilson's kidneys for some reason. That's what these candies were. These candies were nephrotoxic. Can you guys just give me 1 second, please? Okay. So what we were saying was we wanted to come up with a mnemonic for the Fanconi syndrome causes. So first of all, let's go once again. That is, this young boy, his name is Wilson. Wilson tries to hide candies. How many types of candies did he have? He had multiple types of candies. And since he loves having candy so much, over time, what this did was these candies, they damaged his kidney. So these candies were nephrotoxic candy. Okay. And these candies were covered by a lead covering, like how we have candies covered by aluminum foils. These candies were covered by lead poisoning. I mean, by lead papers. Okay, so lead. Lead. Okay, so that's what it is. So how will this mnemonic help us understand the causes? First of all, young boy Wilson, his name for Wilson's disease, tries tries for tyrosinemia. Okay, tries for tyrosinemia to hide candies. Hiding of candies. Candies are high in glucose, so hiding of candies can help us remember that this is glycogen storage disease. Glycogen storage disease. How many types of candies? Multiple types. So multiple types of candies for multiple myeloma. Nephrotoxic candies for nephrotoxin drugs such as ifosfamide and cisplatin. Okay. Candies covered by lead for lead poisoning. Okay, so this is a small picture mnemonic that can help you understand the causes of the Fanconi syndrome. Did you guys draw this out in your book? Yes or no? Okay. Okay. Has this picture mnemonic helped you guys understand or helped you guys memorize the cause of Fanconi syndrome easily? Or okay, good. So I'm glad it worked. Always remember that if it's difficult, try to incorporate a story with it. Okay. Okay. So right now, so these are the causes of Fanconi syndrome, and that's the only thing that you have to memorize from this table over here, is that these causes, and you can is that these causes, and that's how you can memorize. Young boy Wilson for Wilson's disease tries for tyrosinemia to hide candies for glycogen storage disease. How many types of candies did he have? Always ask yourself questions. He had multiple types of candies, so multiple myeloma. Candies were nephrotoxic for nephrotoxin drugs. Candies covered by lead paper for lead poisoning. As simple as that. Next one. Next one is Bartter syndrome. Bartter syndrome is the defect in the thick ascending limb of the loop of Henle. Okay, thick ascending limb of loop of Henle. So the thing is, if there is thick ascending limb of loop of Henle, we know that thick ascending limb is responsible for causing hypokalemia, for reabsorption of sodium chloride and potassium ion. So if that is not working, then patients will lose potassium, so patients will have hypokalemia, and patients can also have hypercalciuria. How do patients have hypercalciuria? Do you guys remember that when we talked about um, the thick ascending limb of the loop of Henle, we talked about how the sodium potassium 2 chloride. We talked about how the sodium potassium 2 chloride, they cause the paracellular transport of the magnesium and the calcium, right? So if this channel is not working, then this electrochemical gradient will not form. And as a result, calcium can also not be reabsorbed via the paracellular route. So there's more calcium that is being lost in the urine. And that is the reason why in Bartter syndrome or in a diuretic, which let's say does not let the sodium potassium 2 chloride channel to work properly over there, the patients can lose calcium. That is, they can have hypercalciuria. Okay, and then it also causes metabolic acidosis. Okay, how does it cause metabolic acidosis? If you ask yourself that question, how does it cause metabolic acidosis? Let me see if anyone knows how, if sodium potassium 2 chloride channel is not working, how will it cause metabolic acidosis? I mean alkalosis, that's what I meant, not acidosis. How will it cause metabolic alkalosis? Anyone? Metabolic alkalosis. How does Bartter syndrome cause metabolic alkalosis? Very good. So first of all, there are multiple reasons. The reason which Dr. Hussam mentioned, the reason which Dr. Hussam mentioned is hypokalemia. So what happens is if you have excess loss of water, first of all, this will activate the renin, angiotensin, aldosterone system. More aldosterone will work. If more aldosterone is working, if aldosterone works, will there be metabolic alkalosis or metabolic acidosis? Fast answers, please. If there's excess working of aldosterone, metabolic alkalosis. At the same time, if there is less potassium ion, okay, if there is less potassium ion, will this activate the metabolic? Will this activate the renin, angiotensin, aldosterone? Yes or no? Okay. And another thing is, if there is another one is if there is less chloride reabsorption, if chloride is reabsorbed less, will there be more formation of the acid or less formation of the acid? Less formation of the acid. So overall, what's happening is, overall, as a result, the patients have metabolic alkalosis. In proximal convoluted tubule, patients have metabolic acidosis. Why? Because in proximal convoluted tubule, you have increased excretion of bicarbonate ion. So bicarbonate ion is being excreted more. So increased excretion of bicarbonate ion can cause metabolic acidosis. Okay, and the exact opposite happens in Bartter syndrome, that is metabolic alkalosis. Okay. The next is, what is the cause of Bartter syndrome? The cause is it's an autosomal recessive cause. Okay, so it's an autosomal recessive disorder. That's that. And this is very similar to how furosemide will work. The furosemide also works by blocking the sodium potassium 2 chloride channel. So that's that. Okay, next one. Next one is Gittleman syndrome. Gittleman syndrome is the reabsorption defect in sodium chloride in the distal convoluted tubule. Okay, if the sodium chloride channel is not working, what would happen over there is that the patient once again will have metabolic alkalosis. How? Because of hypovolemia, renin, angiotensin, aldosterone system will be activated. More aldosterone will work, and if aldosterone overworks, the patients will have metabolic alkalosis. Hypomagnesemia. Okay, hypokalemia, hypocalciuria. This is the one where you have to understand. So, if Gittleman syndrome over here, that is the channel in distal convoluted tubule, if that is not working, patients will have hypocalciuria. Why? Why will patients have hypocalciuria? Because if these channels are not working, then once again, that the sodium calcium exchanger will overwork, right? And more calcium will be reabsorbed. So, and as a result, more calcium will be taken from the urine. So the patients will have urine with low amount of calcium ions, so hypocalciuria. So if anyone asks you in which portion, if the channels are not working, in which portion of the segment, if the channels do not work, the patients will get hypercalciuria. Your answer should be the thick ascending limb of loop of Henle. And if they ask you in which portion, on which segment of the nephron, if the channels do not work, which is causing hypocalciuria, then your answer should be distal convoluted tubule. Distal convoluted tubule. Okay, so that's that. Okay, next one. Next one is Little syndrome. Okay, so what's happening in Little syndrome? In Little syndrome, you have a gain of function mutation in which causes decreased sodium channel degradation. Okay, so this channel over here, this channel, okay, this channel, if it overworks, well, there will be more reabsorption of sodium, right? So there is every channel is a protein structure, so it's a protein channel. So for some reason, if there is a mutation in which these channels, they do not degrade, these channels, they stay for a long period of time, more amount of sodium will get reabsorbed from the collecting tubule. And as a result, what would happen is, if there is more reabsorption of the sodium, if there's more reabsorption of the sodium, once again, what would happen is this would activate. This would also cause your metabolic alkalosis. As a result, if sodium is more reabsorbed, then more potassium will leave by the sodium potassium ATPase. So patients will have hypokalemia. Increased amount of sodium can cause hypertension, right? And aldosterone can decrease. Over here, aldosterone decreases, but the patients still have metabolic alkalosis. What is the reason? What is the reason for metabolic alkalosis, even though the sodium has decreased. Can anyone tell me why we have metabolic alkalosis and Little syndrome, although there is hypertension? Anyone? Have you guys understood my question? Yes or no? Why is there metabolic alkalosis and Little syndrome? Can you guys answer the question? Yes or no? No is also an answer. Very good. Okay, no is an answer. Okay. Okay, so first of all, what's happening over here in Little syndrome is that in Little syndrome, what you have is you have cells of, okay, so just tell me this. If we have excess working of this of the channels in alpha intercalated cells, will it cause metabolic alkalosis or metabolic acidosis? If we have excessive work cells in alpha intercalated cells, okay, good. So it will cause metabolic alkalosis. In Little syndrome, what happens is you have gain of function mutation. You have the gain of function mutation in all channels, not only the sodium channel, you have the gain of function mutation in also the channels of alpha intercalated cells. So now, right now, if the channels of alpha intercalated cells, they work for a long period of time, will they cause metabolic alkalosis or metabolic acidosis? Fast answers, please. Metabolic alkalosis. So that is why in Little syndrome, for the gain of function mutation, you have metabolic alkalosis. Are we clear? Although the patients have high amount of sodium reabsorption. Are we clear now? Yes or no? Okay. Okay, good. So you will not be tested how what's happening over here, but you have to understand why metabolic alkalosis is taking place in Little syndrome, or else if there comes a question where you have to apply this knowledge, you might even confuse yourself when you ask yourself, okay, why is there metabolic alkalosis when there's increased sodium reabsorption? Then I immediately want you to think about how in Little syndrome you have a gain of function mutations of mostly all the channels of the collecting duct. So except the beta intercalated cells, you have the excessive working of principal cells and alpha intercalated cells. As a result, you have metabolic alkalosis. Okay, Little syndrome is autosomal dominant. Okay, autosomal dominant, primarily seen in hyperaldosteronism, but aldosterone is nearly undetectable. And the treatment, what is the treatment? The treatment for Little syndrome is amiloride. Amiloride or amiloride, these drugs are used for blocking this sodium channel over here. Okay, so if we want to decrease the amount of sodium reabsorbed, what we can do is we have to block the channels, and the way that we can do that is by this drug that is amiloride. There's also another drug that we can use. That drug is triamterene. That drug is triamterene. Okay, so that's that. Have you guys understood Little syndrome? Have you guys understood Little syndrome? Okay, next one. Very good. Next one is syndrome of apparent mineralocorticoid excess. Cortisol, what cortisol does is cortisol activates the mineralocorticoid receptors. Okay, cortisol activates the mineralocorticoid receptor. First of all, a very basic question: which organ is responsible for secreting cortisol? Very basic question. I just wanna come from all the way from the bottom, and then we can go to the top. Okay. Which gland is responsible for secreting cortisol? Fast answers, please. It's a very easy question. Adrenal gland. Thank you so much. Adrenal gland is responsible for secreting your cortisol. Cortisol, what this will do is they will activate the mineralocorticoid receptors. Okay. Do you guys remember that? Do you guys remember the table that we discussed? How different types of hormones are made from the cholesterol all the way down to the angiotensin and all the other ones? Right. Very good. So cortisol, what this will do is cortisol will activate this enzyme called 11 beta hydroxysteroid dehydrogenase, and this will convert cortisol to cortisone. Okay, and if we have this 11 beta hydroxysteroid dehydrogenase deficiency. As a result, if there's a deficiency, there will be increased amount of cortisol because cortisol cannot be broken down to cortisone, and cortisone it has less activity than cortisol. As a result, increased amount of cortisol activity can increase the mineralocorticoid activity. The mineralocorticoid, if mineralocorticoid activity increase, if it increases, then once again, the patients can have metabolic alkalosis, the same as the patients in hyperaldosteronism, hypokalemia. The patients can have hypertension, decreased serum aldosterone. Okay, cortisol tries to be the same as aldosterone. So what the thing is, when cortisol tries to be the same as aldosterone, they have sign symptoms of hyperaldosteronism, but the serum aldosterone level is less, because when cortisol does the function of aldosterone, there's less secretion of aldosterone as itself, so aldosterone level decreases. Okay. The syndrome of the syndrome of apparent mineralocorticoid excess, this can be acquired from glycerogenic acid. Glycerogenic acid is present in licorice. Licorice is a type of candy that that a lot of kids eat. Okay, let me show you what a licorice is. Okay. So, one second. So these are licorice, okay, Twizzlers. That's what it is. So these type of licorices, they contain a lot of glycerogenic acid. Glycerogenic acid will block the activity of 11 beta hydroxysteroid dehydrogenase. As a result, cortisol cannot be converted to cortisone. Increased amount of cortisol, what this will do is this will cause mineralocorticoid activity. What is mineralocorticoid activity? That is hypokalemia, hypertension, metabolic alkalosis, without increasing the serum aldosterone level. How do you treat a patient with mineralocorticoid excess? Obviously, we have to use potassium-sparing diuretics, right? Because already if there's increased mineralocorticoid activity, more potassium will be released into the lumen. So we have to spare the potassium, so potassium-sparing diuretics. And then we also have to use corticosteroids, that is exogenous corticosteroid. Um, what this will do is that the exogenous corticosteroid will decrease the endogenous corticosteroid production by negative feedback. So there are two treatments for syndrome of apparent mineralocorticoid excess. How do you diagnose a patient with syndrome of apparent mineralocorticoid excess? If you see that the patient have metabolic alkalosis, hypokalemia, hypertension with low serum aldosterone level, then this is known as apparent mineralocorticoid excess. Treat them by two. That is number one, potassium sparing diuretics, and the another one is exogenous corticosteroid. Exogenous corticosteroid will decrease the endogenous cortisol production, and potassium sparing diuretics will spare the activity, will spare the potassium, so the patients will not have a hypokalemia. Okay, are we clear on this whole table? Okay, does this make things a lot easier? Okay, very randomly, if I have to ask you right now, very randomly, without even looking back at the book, can anyone please tell me the causes of Fanconi syndrome? Because this is a very highly important information from this piece of table, from the pictured mnemonic that we just created. Wilson disease, very fast, tries for tyrosinemia, tries to what? Glycogen storage disease, okay, multiple myeloma. Okay. Okay. Very good. Okay. Okay. So that's that. Okay, so if you guys can remember the picture mnemonic, then it will be extremely easy for you to remember all the causes of Fanconi syndrome. Okay, so to remember all the causes of Fanconi syndrome. Okay. Okay, having said that, let's move on. Okay, let's move on to the next page. Okay. before we move on to the next page, since we try to master the first aid overall during our lecture, because we want you guys to spend the rest of your days doing UL questions. Okay, this table about the renal tubular defects. This is a comparatively high yield table. Okay, so can I give you guys 5 minutes to read the table, the one which we just discussed? And what I will expect is after reading the table, I would expect the help of two physicians. If they can help me out, I will ask them questions and they can provide me with answers via active participations. Okay, via active participations. And I will only ask them where the defect is, what the effect is, and only ask the student for Fanconi syndrome that what are the causes of Fanconi syndrome. If they can just only tell me the names of the disease and which portion the disease is taking place, I would highly, highly appreciate it. I need you guys to do this right now during the lecture because I don't want you guys to spend the rest of your day looking at first aid anymore. It should be done. It should be spent on doing questions on UWorld. Okay, so I will give you guys 5 minutes. Okay, 5 minutes to look at these questions, look at the table, I mean, and then volunteer to participate in active participations. Okay, 5 minutes. Okay, so is anyone ready to answer the questions about about the vestibular defects? Okay, anyone else? Anyone else? Do we have anyone else? Okay, we have Dr. Hussam who will help us out. Thank you, Dr. Hussam. Do we have anyone else who wants to participate? Please, I would just need the help of one more physician if they can help me out, because I just want to make sure that you guys have understood. To any physician who has been with us for a long time but have not taken active participations, if you guys would be willing to answer the questions, I would highly appreciate it. Anyone else? It's nothing to be worried about. Very easy questions. All I will be asking you are the names, where the defect is taking place, and what are the causes. Is there anyone else? Okay, if there's no one else, and then can we start with Dr. Hassan? Dr. Hassan, would you be kind enough to tell us where is the defect of Fanconi syndrome?
Yes, doctor. Hello. It's in proximal convoluted tubules.
Okay, so what are the causes of Fanconi syndrome?
Wilson disease, glycogen storage diseases.
Hmm.
Um, TRI stand for thyrozinemia also.
Very good.
Uh, okay, candy we say. Then nephrotoxic drugs,
Very good.
such as cisplatin and cyclophosphamide. Yes.
Awesome. Okay.
Okay. Um, then lead poisoning.
Lead poisoning. Very good. Absolutely wonderful. What is the name of the pathology for the renal tubular defect in thick ascending limb of loop of Henle?
Parter.
Okay, Bartter syndrome. What is the name for the defect on the descent or the distal convoluted tubule?
Lidlman. Sorry, Gittelman.
Gittleman syndrome. Very good. In Bartter syndrome, do we have hypercalcemia or hypocalcemia?
If you are talking about calcium in blood,
Hmm.
there will be decreased. So in Barter, there will be decreased in blood. So
Very,
hypocalcemia.
very good. How about in Gittleman syndrome?
It's like thiazide, so hypercalcemia.
Very good. How about in Little syndrome? Little syndrome, do we have metabolic acidosis or alkalosis?
Liddle syndrome, there will be metabolic alkalosis.
Very good. How about in syndrome of heparin mineralocorticoid excess? Do we have acidosis or alkalosis?
Same alkalosis. I think all of them are alkalosis, yeah?
Exactly. Every one of them is
Except
alkalosis except Fanconi syndrome.
except Fanconi,
Fanconi syndrome. That is correct.
because there is loss of bicarb.
Perfect. That is absolutely correct. Thank you so much, Dr. Hassan, for performing. Has everyone understood? Uh, has everyone understood the renal tubular defects and salt losing nephropathy? Okay. Okay. Good. Okay. Good. Having said that, let's move on to the next page. Okay. Let's move on to the next page. This, what I'm going to do is I'm going to draw a very, very important graph. Okay. This graph is very important. This graph is very important for your U world. Okay, this graph is very, very important for your U world. You guys will receive questions from this graph. Okay, okay. This graph is basically what this graph is that this graph over here has two things. Okay, so this is basically zero. Okay, 1 second. Let me use the red color. Okay, zero. This is 100%. This 0 to 100%. This shows the distance along PCT, proximal convoluted tubule, distance along the PCT. Okay, and over here, what we have is we have the tubular fluid divided by plasma. Tubular fluid of a substance divided by plasma concentration of that substance. Okay, so what we have over here is we have zero. Once again, the zero, and that's over here. And over here, what we have is 2. Okay, 0 and 2. And let's say that this is 1. Okay, okay, okay. So this is 1. Okay, now, now the thing which I want to talk to you about is tubular fluid by plasma. If it's more than 1, okay, if the tubular fluid concentration of a substance divided by plasma is more than 1, does that mean that the substance is more in the plasma or less in the plasma, or more in the tubular fluid and less in the tubular fluid? Have you guys understood my question? if tubular fluid by plasma is more than one, that substance is more in the tubular fluid and less plasma. So if we have a substance that is more in the tubular fluid, has that substance been less reabsorbed or more reabsorbed? Less reabsorbed. So less tubular reabsorption. Okay. The question vice versa is, if the tubular fluid content is less than one, I mean, tubular fluid by plasma is less than one, then obviously the plasma concentration is more and tubular concentration is more or less less. If tubular fluid concentration is less, has that substance been more reabsorbed or less reabsorbed? More reabsorbed. Is it possible to take a 10-minute break before we jump into the next portion and we can discuss this after we come back for the break? Okay, perfect. So we will take a 10-minute break. Thank you. Okay, is everyone back from their break? Is everyone back from their break? Okay, perfect. Perfect. Is everyone back from the break? Can you guys hear my voice? Okay, good. So, okay, good. So the thing is, the lecture for today, the lecture for today, unfortunately, I have to cut it a bit short. I'm gonna cut it to the next half an hour to 45 minutes. I apologize for a very small family emergency which I have regarding my father. We have to report to the hospital at 12:30 New York timing. So is it okay if I cut the lecture to a little bit shorter and I will make up this timing tomorrow? And I'll teach you and I'll start the lecture a bit faster and I will make sure that we're not left behind on any of the pages. Okay, I will make sure that the lectures are not left behind on any pages and we are ahead of our schedule for this week. Okay, so we will cut the lecture a bit short, but eventually what we will do is we will make up the timing and that's that. Okay, I completely apologize for everything that's been going on with my father. The thing is, my father is a patient of a vocal cord carcinoma, and he needs to have a very big surgery done. That is a radical laryngectomy with lymph node dissections. And we're just going through an issue with him. Last week he had a biopsy. This week he needs to have surgery. Okay, so the thing is, please keep my father in your prayers. But the thing is, these things will not affect our lecture. We will make sure that we are always ahead on our schedule. Okay, so having said that, let's read one more page, and after that, what I want to do is I want to jump into the UWorld questions and UWorld notes, and I want to make sure that the pages that we have missed out on, we can make them up as soon as possible. Okay, we can make up for those pages as soon as possible. Having said that, let's begin the lecture. Okay, let's begin the lecture. Can you guys see my screen? Can you guys see my screen? Okay, perfect. Okay, so what we were talking about was tubular fluid divided by plasma. So once again, all I want to know is this is a very high yield. This is a very high yield graph. That is, if a substance is more in the if tubular fluid by plasma is more than one, if tubular fluid by plasma is more than one, will there be more substance in the tubular fluid or less substance in the tubular fluid? That's all I want to know. More. Okay. If the substance in the tubular fluid is less, then my question to you is, will there be more reabsorption or less reabsorption? Okay, good. If the substance in the tubular fluid is less, that means there is more reabsorption. Okay, good. Now let's talk about a substance that is creatinine. Is creatinine more reabsorbed or less reabsorbed, knowing it's a waste particle? Less reabsorbed. If I ask you, creatinine, which portion do you think creatinine will be in A or in B? A. Very good. So we're going to draw a line for creatinine. The line for creatinine is this line. This line is for creatinine, more or less, because this will stay above. Okay, so this is creatinine. Okay, next one. Next one I want to ask you is, if I have to draw, if I have to, okay, next one is, okay, if I ask you the next one, that is inulin, where will inulin be the most, A or B? A or B? Inulin will be more in A. Inulin will be more in A, right? So inulin will stay very close to like this, okay? Inulin will be almost, if not the same as creatinine, okay? Because inulin is less reabsorbed, right? Inulin will stay like this, okay? Good. Next one is urea. Urea, where will urea be? A or B? A. Okay, urea will be in A. This is urea. Okay. And if I ask you about something such as glucose and amino acids, where will glucose and amino acids be? B. Very good. More or less completely reabsorbed. So glucose and amino acids, they will be over here. Glucose and amino acid. Okay. Next one. Next one is if I ask you about bicarbonate, where will bicarbonate be? Is bicarbonate more reabsorbed or less reabsorbed? Very good. So this is bicarbonate. Okay, so this is bicarbonate. Okay, good. Now I want to talk about the ions. Okay, we know that potassium is less reabsorbed than sodium. Sodium will stay almost more or less, if not the same, as the same rate as water. That is, they're almost equal to one, almost equal to one. Okay, sodium, potassium over here will stay like this because it's a bit, potassium is more secreted and sodium is more reabsorbed. Okay, and then we also have another one, that is chloride. Okay. Okay, you guys will receive a question in your UWorld. If you guys have not already received this question, you guys will receive a question in your UWorld where they will ask you, okay, you guys will receive a question in your UWorld where they will ask you, okay, so this is 0, 1, and 2. Now they will ask you is, what, which substance does this line and this line and this line represent? Okay, the answer options are, okay, so let's say A, B, C. Now my question to you is, which substance do you think A is? A. Creatinine. The thing is, creatinine is more like this. Creatinine is more like this. Okay, but this one is very close to 1. This A is very close to 1. If I tell you this A is very close to 1, which substance is A? Urea. Which substance is B? B. Which substance is B? Very good, very good. And which substance is C? Glucose or amino acid? Glucose or acid, depending on which one is given. Okay, have you guys received this question you will as of yet? Okay. If you guys have received this question in UWorld, then you know that this is an actual UWorld question. And as a matter of fact, you guys will also be tested. My question is okay, for Dr. Mohammed, what is the question? The question is, which substances represent the letter A, B, and C? A, B, and C. Which substances represent the letters A, B, and C? The substances are urea, bicarbonate, and amino acid. Are we clear? Okay. Okay, good. So having said that, I wanna stop the first aid lecture over here, and I want to make sure that we can continue this tomorrow, and then we can have we can put in the extra timing, the timing that we lost over here. And what I want to do is tomorrow, is it possible if I start a lecture a bit early so that we can get ahead of the schedule? Is that okay? Okay. If I start the lecture, say 8 in the morning, would that be okay for you guys so that I can make up for the extra time that we have lost today? Yes. Okay. So that sounds perfect. So the lecture tomorrow will start at 8 a.m. The lecture for tomorrow will start at 8 a.m. and we will try to take the lecture till 1 or 2 so that we can make sure that we are not left behind on our schedule. Okay. Okay. So having said that, I want to discuss some renal questions with you guys. I first of all, let me apologize one more time for cutting the lecture short today because this was a very unexpected call. Okay, I really was not expecting to cut the lecture short or anything. Okay, but I apologize. There's absolutely nothing I can do. But I can promise you guys, what I can do is I can absolutely promise you guys that I will make up for this lecture, the one which has been cut short today. We'll make this up for tomorrow. Okay, and having said that, let's begin the UWorld questions. That's all I want to do. That's what I want to do today. So just give me 1 minute. Let me prepare UWorld questions. Okay, let me prepare the UWorld question. Then we can move on. Okay, so we will do our regular UWorld 5 UWorld question, offline question. Thank you so much for keeping my parents in your prayers and understanding the problems that I'm going through. But what I can promise you is this will not, I mean, I will not let this affect the lectures. This will not be an issue because we will make sure that that we cover the lecture, the hours that we have missed today. We missed around 1 hour, 1 to 1.5 hours of lecture because we usually conduct the lectures for till 1 p.m. So I will make this up tomorrow at 8 a.m. And what I will do is I will start the UWorld questions. Nope, that's okay. That's completely okay. We still have time for the UWorld questions. No problem. This is an important segment, especially for the new students who has joined the lecture. I don't want them to think that we do not do UWorld questions. Okay, so we will start with our UWorld questions. That's what we will do. And let me just share my screen. Let's begin. Let's see what's going on over here. Okay. Okay, so if you guys would be kind enough to unmute yourselves and read the question and let's see what's going on. So what I will do is, okay, first of all, please only answer when I ask you, and that's what we will do. First of all, when you see a question as big as this, okay, this is for the purpose of new students. So first of all, we all have 90 seconds to solve a question as big as this one. So the first thing to do is read the last line of the lecture, the last line of the question first. Okay, then we have an idea about what the question is asking you, and then we can understand this a lot better, and this will allow us to solve the whole thing in 90 seconds. Okay, so having said that, let's begin our first question. That is, which of the following structures is most likely to be lacerated by the fractured bone? Okay, so they're asking about a structure being lacerated by a bone. Okay, the question is, a 21-year-old man comes to the emergency department after suffering an injury during a football game. He was falling to the ground when he was struck forcefully from behind the helmet of an opposing player or opposing player. The patient was able to ambulate after the injury, but has since had severe pain worsened by deep breaths. Okay, so none of this is still very high yield. Blood pressure is this, pulse is this, respirations are 16. So respiration is okay. Okay, on examination, there's a bruising and tenderness of the left posterior chest wall, normal spinal range of motion, and no midline tenderness. Gait and lower extremity examinations are normal. Imaging studies reveal a fracture of the 12th rib. Which is the correct answer? This is the only line that is important. Now then,
B, doc.
Left
B.
kidney, B.
Left kidney.
this is a very easy question compared to, because we are studying the renal system right now. Of course, the answer is kidney. Okay. If we were studying something else, this would have been a much harder question. But then again, this question was not that hard because how it said that they had a fracture of the 12th rib. So all the students who said B is the correct answer. And the percentage of students who has answered B is actually 75%. Okay, so this was a pretty easy question. Okay, next one. Okay, next one. Okay, let's see. Okay, apologies for the picture. Let's see what's going on here. Okay, the question is, the majority of the total amount of water filtered by this individual's glomeruli is reabsorbed in which of the following portions of the nephron? The question is, a 54-year-old missionary traveling alone in a remote region of Southern Asia becomes lost. After several days, he arrives at a small village. However, he has gone 24 hours without food or water. Urine osmolarity is 1,000 and 150 milliosmol. Which portion is the majority of the water reabsorbed?
Proximal tubule.
Proximal tubule.
E.
E.
Okay, take some time and read the question once again.
B or C? C.
Read the question once again, please.
D.
Median.
D is the medullary collection.
Medullary collecting duct.
Okay, what's going on over here? What's going on over here is,
Dehydration.
the majority of the total amount of water filtered by the individual is reabsorbed in which of the following portion? So the,
Proximal.
Proximal tubule.
oh,
Yeah.
Proximal, doctor.
I
very
think he
good.
explained this last
65.
time.
Till 80.
Dr. Proximal, because they're talking about the filtered water, not the final urine.
Okay, so now, okay, so the timing for answering is over. Okay, so now is the time to explain. So if I can correctly hear, I think it was Dr. Hossam. Dr. Hossam mentioned that the majority of the total amount of filtered water, and to all the students who said proximal tubule is the absolutely correct answer. Okay, because the water that has already been filtered is reabsorbed. Filtered water reabsorbed, the highest segment of absorption occurs in E. Okay, what happens in medullary collecting duct is also responsible for reabsorption of water. Okay, but the thing is the maximum portion of the reabsorption will occur along with sodium. So if the maximum amount of sodium is being reabsorbed in the proximal, that is 65 to 80%, the maximum segment of water, the maximum amount of water that is reabsorbed is in the proximal tubule. So that is the answer. Are we clear?
Yes, doctor.
Okay, perfect. Easy question, easy answer. This one is a bit difficult. Okay, now, okay, so let's read this together. Let's see what this says. Which of the following is the most likely cause of her condition? A 48-year-old woman comes to the office with a 6-month history of involuntary passage of drops of urine when sneezing or
Doctor, we
coughing.
have done this question
I
before.
think we've done this
Yeah,
question.
we've done this question last time,
Oh,
even the
perfect.
previous
Yeah,
one.
you read
Yeah.
the speaker this much.
So off zone.
This one. Very good. Okay. Okay. If I have to ask you, if a person has incontinence during sneezing and coughing, what kind of incontinence was that question?
Stress.
Stress incontinence.
Very good. Let's read this question together. Let's see what this says. Which of the following will most likely be present in a newborn after delivery? A 24-year-old woman comes to the office for a routine antenatal ultrasound. She is 19 weeks pregnant. This patient's had pregnancy and there have been no complications. Her family history is unremarkable. Both are healthy. Ultrasound reveals a male fetus with bilaterally enlarged fetal kidneys with diffuse ball cyst. Amniotic fluid volume is low. Okay. Which of the...
Yeah, we did this before.
I think we've done this.
No, no, no. We didn't.
No, we didn't do
Oh,
this
no.
one. That one was a
We
different
didn't
one.
do this.
Okay. So this is a different question.
D, respiratory distress.
Okay. So all the students who said respiratory distress, can I hear the
No, no.
pathological...
Potter syndrome.
Only go ahead, Ramon's teacher.
Okay.
Potter
What's the
syndrome.
pathology?
Potter syndrome.
Potter syndrome, yeah.
Potter syndrome, very good. Potter syndrome. So this question about Potter syndromes, they are very, very common. Okay, they keep on coming again and again and again. Okay. The next question I want to discuss is this question. But the thing is, I'm not sure if the text is of high resolution. It's a bit blurry. Okay, just let me see if I can still read it out. As a matter of fact, this question is actually very easy. If you guys can already see the picture, you guys know what's
Yeah.
Horseshoe.
Horseshoe
Horseshoe
kidney.
Kidney.
CT scan of the abdomen is shown, and this image is shown below. Physical examination reveals suprapubic discomfort. Urine analysis shows pyuria and many bacteria. Okay, let's see what the next portion is. Okay, the next question is, pretty sure you guys can make the answer right away. Can I hear?
IMA.
Hey.
Okay, so that is the right answer. Okay. Okay, so we have a lot of confident students over here. Thank you so much for not even reading the question. So you guys are so confident that you guys can just see the picture over here and just answer that the artery is inferior mesenteric artery. Okay, so we did 4 questions. Let me just upload another one. Let me see if there's a difficult question I can challenge you guys with. Okay. Okay, so we have a pretty difficult question. Okay, this question is so difficult that the majority of students who has answered this is 20%. Okay, give me 1 second. Okay, so we have to take this question into consideration about how difficult this question is. Okay, if you guys have not received this question yet, you guys will receive it. Okay, what's going on over here? Which of the following is the most likely sequence of structures traversed by the trucker and cannula during the procedure? What is the procedure? Most probably the procedure is a suprapubic cystostomy. A 65-year-old man comes to the emergency department due to severe lower abdominal pain and nausea, not been able to urinate, has a history of hypertension, BPH. On examination, a large mass is palpable in the suprapubic area, that is the distended bladder. Multiple attempts at urethral catheterization are unsuccessful. Ultrasound-guided midline suprapubic cystostomy. That's what I said. Now, which of this is the structures that is traversed by the trucker and cannula during the procedure? Let's see what your answer is. Let's take a second to read the answer options and let's see what your answer is. If anyone is ready to answer, please say I'm ready.
I'm ready.
Okay, so only 1 student is ready. Let's see if anyone else is ready.
I'm ready.
Ready.
Okay, 4 or 5 students. So let's see. The first physician who said I'm ready, most probably was it Dr. Mohammed?
Yes, doctor.
Okay.
I think it's A.
Dr. Mohammed is A. Do we have anyone
E,
else?
E, not A, E.
Okay, Dr. Mohammed is E. Okay. Anyone else?
B.
E.
I think
E.
it's A.
D.
D.
Okay. So this is the reason why this is hard. Okay. So before I answer this, let me tell you the layers of abdominal wall from the outside to inside. First of all, we have skin,
You're not gonna go through the peritoneum.
superficial fascia of camper. Next one, superficial fascia of scarpa. Have you guys heard of Camper's fascia and scarpa?
Yeah.
Fascia?
Yes.
Good.
Yeah.
Very good. Next one is external oblique. Okay. Then, okay. Next one is internal. My apologies. Internal oblique. Next one is transversus abdominis. Next one is fascia transversalis. I'm pretty sure I discussed this during the
Last
gap.
time, yeah, I think it is.
Okay, I'm going to discuss once again. Then extra peritoneal tissue and parietal peritoneum.
Yeah.
Having said that, now since we have discussed the layers of the abdomen, now can we go back and make the correct answer? Now let's see what the answer is. Before you answer, try to understand if bladder is a retroperitoneal structure or it stays in front of the peritoneum.
I think, teacher, the bladder is extraperitoneal structure.
If the bladder is extraperitoneal, what is your answer?
E.
Everyone, what is your answer? You guys should be very confident right now and tell me the correct answer right away. After
D.
we do.
C.
D. It's D.
Okay. So let me take you out of the misery. Okay.
A, because it's gonna pass the aponeurosis first of the MRSA.
Okay. So who are the students who has said A? We heard Dr. Mohammed.
I
And-
said A.
A.
I'm going
Okay.
for A.
Okay. Can we ask our another students to see what they think too? Can we ask Dr. Adenom? Dr. Adenom, if
I
you would
think it's C.
C.
see. Okay. Anyone else? Dr. Adenom, Dr. Mon, and we have Dr. Gianni, Dr. Iman, Dr. Hassan,
D.
Dr. Okay.
D.
Okay, perfect. So what I'm going to do is I'm going to answer this question for you. Okay. The answer is A. The
Yeah.
correct answer is A. Okay. The amount of students who has said A is 21%. The amount of students who has said B and C are 27% and 19% respectively. A is the
Because
correct
the
answer. What I'm going to do.
aponeurosis of external and
Exactly.
internal oblique.
Right. So you have the external and internal oblique aponeurosis.
Yeah.
After that, you have transversalis fascia. And before you reach to extraperitoneal connective tissue and parietal peritoneum, since bladder stays in front of the peritoneum, then you will have the bladder wall. It's absolutely impossible to reach the peritoneum before because the peritoneum stays behind the bladder. Over here, it's not, the answer is not C, because the answer is not C because aponeurosis comes before transversalis fascia. Transversalis fascia does not come after aponeurosis. Same thing over here. Aponeurosis will come before, not after. And over here, they skipped out on aponeurosis. So this is not the correct answer. The correct answer is A. Are we clear?
Yeah.
Yeah.
Okay. So in order for you guys to answer this question with absolute confidence, you guys have to understand the layers of the abdomen from outside to inside completely. In between the transversalis and the fascia transversalis, that's where your bladder lies. Okay, so having said that, thank you so much. Have you guys understood the UL questions that we have just discussed? Okay. Okay, so having said that, it's 11:42 as of right now. We would have ended our lecture at 1:30. So we have to make up for an extra 1 hour which we are going to lose today. We're going to make that up for by doing an extra hour tomorrow. So what we will be doing is tomorrow we will be starting our lecture at 8 a.m. in the morning. We'll be starting our lecture at 8 a.m. in the morning. And thank you so much, guys, for understanding the issue. That's that. Okay. Just want to make sure if everyone is okay, if I have upset anyone by ending the lecture fast, I apologize. I'm really sorry. I know you guys did not expect this. But having said that, please trust me, and I promise you that I'll make this lecture up. Absolutely, we will have no problem with the schedule. We will be on our schedule, and we will not be left behind. Okay. So having said that, thank you so much. If there is nothing else, then I would like to take my leave, and I will make sure that we start tomorrow early morning at 8 a.m. And that's that. Okay. So thank you so much. If you guys have any questions or concerns regarding the lecture, please send us an email. And if you guys have anything that you want me to discuss, please send us an email regarding the things that you need help with, and we will try to make a separate lecture video for that. Having said that, thank you so much, and hopefully I'll see you guys tomorrow at 8 a.m. Thank you so much for keeping my father in your prayers. Thank you so much. Okay, have a great day, guys.